Say, y'all, I don't feel good. And I put my head down. And I just recall the nurses saying that they came to me, they lift me up, and I looked like a ghost. Like all the color had just drained from my face.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response RN podcast. Today, I have a very special guest. Not only is she another nurse, she was also a patient, and she also happens to be a nurse podcast host as well. I found Shenell because we were both finalists in the Nurse.org Best of Nursing Podcast Host Award, and it is always such a privilege to meet another nurse podcaster. So Shenell, welcome to the Rapid Response RN podcast.
Thank you for having me, Sarah. Thank you so much.
Yes, I'm so glad we met. All right, so today we're having an important and deeply personal conversation about ectopic pregnancy. It's a medical emergency that Shenell has experienced not just once, but twice. So as a nurse, she spent her career caring for others, but in these moments, she found herself on the other side of healthcare, facing the fear, uncertainty, and grief of a life-threatening diagnosis. Shenell brings a unique perspective, blending both science behind ectopic pregnancies and the compassionate heart of nursing and caring for patients who experience them. So I wanted to say that if you've experienced pregnancy loss, I want to acknowledge that this conversation may be difficult. You may find comfort in hearing Shenell's story, or it may feel like too much right now, and that's okay. This episode will always be here when you're ready. Grief has no timeline, and you don't have to rush your healing. So if you choose to continue listening, we're honored to share this space with you. But if you need to step away, know that you're not alone. So Shenell, thank you so much for your willingness to share your story. I know that it will help so many nurses, both professionally, but also personally.
Yes, Sarah. Thank you.
All right, Shenell. Well, let's do it. Can we, before you dive into your experience, can you just tell us a little bit about yourself, your nursing career? What areas have you worked in? What are you up to in nursing these days?
So I've been a nurse for over 14 years. I got my bachelor's of science in nursing, and I started working med-surg step-down, and I did that for 4 years. And I knew I wanted to do CVICU because I got experience with second-day post-op open heart surgery patients on the step-down unit. And so I really wanted to do that. And so I eventually transferred to CVICU, and I did that for about 4 to 5 years, and I just loved teaching. So I just wanted to share my knowledge with everyone else. And so with that, I decided to go ahead and get my master's in education. And I started to work PRN and NCV. And then I started taking on an adjunct faculty role to be a clinical instructor. And I did that for about a year. And then come 2020, COVID hits.
Yeah.
I'm pregnant with my rainbow baby, who's due in April. And then the world just closes up, right?
April of 2020?
Yes.
Oh my gosh,
Yes.
What a time to have a baby. Okay.
Yes. My rainbow baby. And so the world closes up, and I decide that as I'm going back into nursing, that this is a good time to take on a full-time educator role.
Okay.
So I actually move into nurse staff development. So I'm currently a staff development specialist for the hospital that I work with, and I help oversee orientation for nursing and nursing staff. But very specifically, I help orient or assist with nursing orientation to ICU and neuro ICU and neuro step down. So the new nurses come into those units as well. And I help facilitate their critical care classes and all the other things that come with developing staff.
Love it. Love it. And you get to use your degree to support other nurses.
Yes.
Our paths are very similar, from CVICU, getting the master's education, doing adjunct teaching. Yes. Love it, Shenell. Okay. Is there anything that you want to share with nurses before we dive into your story about your life-threatening emergencies?
Yes.
Plural.
So in my passion for nursing, during 2020, and I think even with the rapid response RN, that's when your vision for this came along. And so I had actually sitting there, I'm like, I'm not out there with my fellow nurses. And so I was like, how can I help them? And so I started a nursing blog, All One Nurse.
Mm-hmm.
And I really didn't get to do much with it, but the goal was just to shed some light for nurses to actually take care of themselves.
Yeah.
Like, who's taking care of the nurse while the nurse takes care of everyone else?
Mm-hmm.
And so my message to nurses are, don't forget to take care of you.
Amen.
Do not forget to take care of you. Self-care is so important because we carry so many hats. We want to do so much. And it's not that we want to, but we're actually doing a lot as nurses.
Mm-hmm.
But we got to remember to take care of the nurse.
Yeah.
Take
Amen.
care of the nurse, whether it's setting boundaries. And like you've mentioned before, saying no to things so that you can say yes to the right things. And you have to think about it. We're not exempt from becoming patients ourselves, as we will see with my experience. So just definitely take care of yourself while you strive to take care of everyone else.
Yeah. Amen, Shenell. Amen. We always need that reminder.
Yeah.
I think as nurses, we're just so wired to be thinking about other people.
Yeah.
But even though that's important, if you haven't taken care of yourself, then you cannot take care of the other person very well either. You're just pouring out from an empty cup. So you got to fill that cup up to pour out. Amen. Amen.
Yeah.
Okay, let's talk about your personal journey. Can you just walk us through maybe the timeline of your experience with pregnancy? Thank God for your precious rainbow baby.
Yes.
But you just share whatever you want to share as far as like how that looked like for you.
Okay, so just to give you a full history, if you had to read my medical history, because I had to go back and just look at some of the things that happened with me, my physician wrote for my reproductive history, gravida 6, para 3, meaning 3 live births, aborta 3, including 2 ectopic pregnancies, 1 treated surgically, 1 treated with methotrexate, and 1 was actually a miscarriage that was treated with the DNC at the time. So multiple pregnancies. But when it comes to this journey with the ectopic pregnancy, it was very challenging and life-changing, and it really deepened my compassion and empathy towards the patient experience.
Mm-hmm.
Because, as nurses, especially if you come out of high school going into nursing, we're young, we're healthy, we're vibrant. And we are definitely, if you feel like it's a calling, as I do, then I'm going to do my best. But it's different when you actually become the patient and you have on that gown with no clothes, with nothing up under it, and you're laying down on this bed or stretcher and looking up.
Yeah.
So just to kind of give you a good storyline, I was a teenage mom, and it was a healthy pregnancy. And, they say ignorance is bliss. So all was well, had the support of my family, continued to go on and get my nursing degree, all that great stuff. But I was on birth control for like 11 years. And then me and my husband decided that we're going to have kids together. And so come 2016, I decide that I'm going to actually go into work on my around the last day on my med-surg step-down unit. Because at 2016, that's when I transferred to CVICU. So I decided to actually go into work to go help out on med-surg step-down. And I'm in a room, patient room, and I'm signing the whiteboard. And I talk to the patient, I introduce myself, and I start to feel this dull but nagging pain in my bottom, Sarah.
Mm-hmm.
And so I'm like, okay, I will be back. And I go sit at the desk, and it's getting worse. And I just sit down and I say, y'all, I don't feel good. And I put my head down. And I just recall the nurses saying that they came to me, they lift me up, and I looked like a ghost. Like all the color had just drained from my face.
Oh, my goodness.
And so they ERT me, which is emergency response team for family and employees. And so they ERT me, get me down to the ED. I'm having severe abdominal pain. And they start fluids on me.
So real quick, did you know that you were pregnant at this time?
Yes. Oh,
okay.
Yes. I knew I was pregnant. We stopped birth control, got pregnant. no issues.
Okay.
I was actually due for my ultrasound the next day.
Oh, okay. So you were what, like 6
Yep.
to 8 weeks? Where were
Around
you?
6
Okay.
weeks. Yeah, between those 6 to 8 weeks, because there was no indication that I needed an early ultrasound because all was well.
Right.
And so I was actually scheduled for the ultrasound the next day. And I decided I was going to go in and help out at work. And this happens. This start having rectal pain, severe abdominal pain, feeling faint, get me down to the ED. They start IV fluids on me. And I just remember the house supervisor, like she was with me the whole time. And not just with me, but with me, like leaned in. Shenell, I'm here. And based off the assessment, her questioning, she knew that I potentially had an ectopic pregnancy that had ruptured. And so get me to ultrasound. They do a transvaginal ultrasound. And the tech only sees internal bleeding. So they only see fluid in the abdominal space. Ultrasound confirms that I'm bleeding internally. And they get in touch with my OBGYN, who luckily was able to come over, and they get me to the OR. I remember the house supervisor walking with the surgical tech. Like, they're both taking me to the OR room, get me over into the table. And I just remember, like, I got to throw up. And I remember throwing up in that OR room and laying back.
Oh, my gosh.
And then I just wake up in a pre-post-op unit. And so if you think back in a normal pregnancy, where the ovary releases the egg, it sits in the fallopian tube, and then the strongest sperm meets that egg and it begins to fertilize, right? So that fertilized egg is supposed to move into the uterus and attach to the lining of the uterus and grow, potentially have, healthy pregnancy. Well, in an ectopic pregnancy, the most common area for that pregnancy to happen outside of the uterus is the fallopian tube, right? And that's what happened. Some other locations may be the cervix or the ovary or somewhere in the abdominal cavity. But in my case, it was in my fallopian tube, my left fallopian tube. And so with it rupturing, I immediately had to go to surgery.
Right. Because you could bleed out.
Yeah.
That's what's so crazy. Even though you're only 6 weeks pregnant, this is a very, very tiny, tiny embryo there.
Yes.
The fallopian tubes ain't having it.
Nope.
And whenever they rupture, you lose a lot of blood really fast.
Yes.
Which is why you're passing out and looking so pale and not feeling good. Yes, I have seen patients crash really, really fast.
Yes.
For ectopic pregnancies. What's challenging is so often, you knew because you were trying to get pregnant. So often patients come with abdominal pain, they don't even know they're pregnant. Like, that's so early in the pregnancy. That's not even on our radar. Right. Oh, it must be an ectopic pregnancy. We're just like, oh, you got abdominal pain. It's probably your appendix. Yep. It's probably gas. We just kind of like, write it off as something else.
Yeah.
And then sometimes very early on, like a urine pregnancy test will even show up negative. Because you're like, oh, well, she's not pregnant. You really have to get that serum ACG to confirm pregnancy or not. And then like you had the ultrasound really is the most diagnostic for this condition.
Yes.
Oh my gosh. All right. So left side fallopian tube.
Yeah.
They had to remove.
Yep. And ovary.
And your ovary. Okay. Yep. All right. So you have uterus still in place and only the right fallopian tube and the right ovary. Okay.
Yes,
got
ma'am.
It. And then to recover from that is, so traumatic, both physically, but emotionally. Like, you were so excited about this pregnancy. And
yes.
How were you doing with all that? How did you recover from that?
Now in hindsight, with having 2 different ectopic pregnancies, the first one with the emergency surgery and getting the laparoscopy done, where she made 3 incision sites, and versus the laparotomy, where she had to do a larger incision to actually explore. But having that done, I was more grateful that I actually went to work that day. Versus if I would have been at home by myself, I would have tried to lay down and rest.
Oh.
So it's just wrapping my mind around, oh my God, I'm so thankful that I was actually at work and it saved my life. Saved my life.
Wow.
And so I had to really recover more. It was more challenging physically because now I just got to recover from having that procedure done. But I'm more grateful that my life was saved versus mourning the loss of a pregnancy that was non-viable. So the perspective was kind of different because I'm like, I want to live,
Yeah.
I want to live.
Yeah, and you did.
When you jump into the second ectopic pregnancy, if I could just jump right into that one.
Okay.
I was actually in CVICU. And I remember reapplying a patient's restraints. It's funny in hindsight, but the patient, he was a little mean or confused. But either way, I remember him telling me, I wish you'd die. And I was like, Mr. So-and-so, that's not nice. And so I'm reapplying the restraint. And then I go back out into the nurse's station. I'm working and I start to feel this familiar rectal pain. And I'm on birth control because I want to prevent another ectopic pregnancy because my risk just went up for ectopic pregnancies because of the first one. And so I'm like, I'll be right back. I go to the restroom. The rectal pain doesn't ease up and I start to feel faint-like. And so the way our unit was set up, the restroom and the break room was right there together. And so I go right into the break room. My housekeeper's in there and I just tell her, go get so-and-so, go get so-and-so. Go ahead and tell her to page ERT. I think about the faint. Like I have this fear over me that I am like a doom and gloom, like I'm about to rehash everything that I've experienced in the past.
Yeah.
But I'm on birth control. We're not trying for a baby. We're not trying. And so they come, they bring a Dynamap, check my blood pressure. It's flashing really low. And I just remember that ERT me, another coworker, he picks me up and lays me on the stretcher. And I'm on my way down this long hallway that lead to CVICU. And I'm on my way back to the ER. They do a serum HCG, which is the pregnancy hormone. And they come back and they say, Shenell, you're pregnant. And I just immediately start crying because I don't want to face this experience again.
Right.
But luckily, they did a transvaginal ultrasound and they did not see any gestation. So they couldn't see a fertilized egg. It was too early.
Okay.
And so I was just told to follow up with my OBGYN very promptly. And I did. Like 2 days later, she does blood tests and she does another transvaginal ultrasound. And she sees it in my only fallopian tube, in my right fallopian tube. And so this time, since it's early on, she wants to give me the option for methotrexate treatment.
Right. So because your fallopian tube hadn't ruptured, we can just locate the ectopic pregnancy.
Yes.
They went with the medical option versus, or like pharmacological versus surgical.
Yes.
Can you talk a little bit about methotrexate? Like what is it? How does it work?
Oh, yes. So methotrexate, she explained to me that it would inhibit that fertilized egg from growing. Like it's kind of like a chemo drug, but it will stop that fertilized egg from growing and actually allow my body to reabsorb the tissue. And I was like, well, how did that work? I only got one tube. And if we do this medicine, it's going to block my tube. And she was like, no, it actually allows the body to reabsorb that tissue. And I was like, okay. And it was an IM injection. And she gave me kind of a lot of instructions because I'm thinking, well, it's early on because my HCG at that time with the second ectopic, when she checked, it was like 700.
Okay.
Or when it was in the ED, it was like 700 versus with the ruptured tubal, it was 14,000.
Oh, okay. Yeah.
So it was different. And so she told me, go home and do nothing. Because I said, well, since it's so early, can I just get the medication, just go back to work? And she said, if you were my family member, I would tell you to go home, lay on the couch, and do nothing. And I said, yes, ma'am. And so no strenuous activities like exercise, no sexual intercourse, of course. And she said I may be sensitive to sunlight with this medication. She told me to avoid folic acid. So stop taking prenatal vitamins.
Yeah.
And so I had to stop taking my prenatal vitamins. She told me I would experience some cramping, which I did. I did start experiencing cramping with the medication. And then she checked my serial HCG levels every so many days. And so I had to keep going back to the office, to her clinic, to get my HCG drawn, or my blood drawn for HCG level. And a week or so into, my HCG levels weren't declining as fast as she wanted them to. So I had to get a second dose of methotrexate.
Oh.
So another IM injection. And I think this time, with this ectopic pregnancy, it was more emotionally taxing.
Yeah.
Because the treatment was longer. Like it was a longer period of treatment.
You kept having to face it. Back in the office, more HCGs. And that's a lot.
And you think about it with my doctor's clinic, their group, the lab is located inside the clinic, inside the waiting room. And so I'm having to go back. And it's not that, oh, well, look at them. But like, man, I got to keep coming in here. And I got all these
with
women.
all the other pregnant women.
All these other pregnant
their
women.
Cute little bellies. Mm-hmm.
And I still got these pregnancy hormones. So I still have the symptoms, the nausea, the cravings, the tender breast, but with nothing to show for it.
Yeah.
Nothing to show for it. And then I'm having to get stuck every so many days. And then to be told, okay, we're going to have to do it again. Give you another shot of methotrexate. Go home, do nothing. But keep coming back here to have your arm stuck with a needle to get blood drawn. And so that was very challenging emotionally.
Yeah. Thank you for sharing that, Shenell. I feel like as an ER nurse, that was my background. I gave methotrexate to a bunch of women. But having never experienced the medication personally, all I knew was to tell them what they would feel with the shot. But as far as what to expect for the next several days, I feel like you have so much insight into what that looks like. Did they prepare you for what you would feel? Like you're still going to feel pregnant. You're going to have to come back and get blood draws multiple times. Like, did they prepare you for all that?
Yes, I think with my physician, and one thing I'm thankful for because, I was already getting my annual exams there, and I think with the emergency surgery, we kind of became friends. She saved my life. She saved my life. She communicated very clearly to me what I would experience. And one thing I loved about her is that it wasn't just what she said, but it was how she said it.
Okay.
So it's like
what did she say that was impactful or helpful?
She was just like, we have this option that we don't have to do surgery. And I would like to do methotrexate. Instead of like, I know I'm going to do methotrexate, but I would like to do methotrexate.
Okay, yeah.
Since it's early on versus, okay, I'm going to give you this IM shot. It's methotrexate and this, that, and other. So she kind of came up in a way like she was conscious of how I received the information that she had to give.
Yeah, that's good. I mean, just little tweaks in our verbiage makes a big difference. Like you already feel like so much power has been taken away from you as the patient. There's so much is out of your control. Then to be told, and now we're going to do this, and now we're going to do this. But instead she said, I would like to do this. Yeah. And here's our option here. And here's the rationale behind it. That is a much more digestible way of giving news. And then just like, and now here's what's next. That's a good point. And then just from the nursing side, for those that have never given methotrexate before, it is a chemotherapeutic agent. And so at least at my hospital, the way it comes from the pharmacy is like it's specially packaged. You have to use all of like the same chemotherapy precautions. It has to go in a special bin when you're done with the syringe. Even the way that like the medication is administered, it has like special devices for drawing the med up. It's just a little different. Nothing to be scared of, but just it's a little bit different. So just to be aware of that. But it's not chemotherapy like patient's going to go home and lose all their hair. Right. Like it's not that strong of a dose of chemo. But like her doctor told her, you're going to feel a little rough for a bit. Not only because you still have pregnancy hormones, but we just gave you a chemotherapeutic agent. So go home, rest on the couch. You're going to have some cramping. Just be prepared for that. But I'm glad that she prepared you for that rather than just like, all right, you're going to go on home. Like, there's a lot more that you have to face afterwards.
Yes.
That you would want the nurse to know to share with their patient as far as like side effects, safety precautions, follow up, like anything what you would make sure to include if you were to care for a patient experiencing what you experienced.
Addressing the patient. Like you can have all this great information for them. Their mental state is not there.
Right.
It's kind of hard to give them, make sure that they follow through with it. And so really just acknowledging the patient and just saying, how are you? Before you actually get into, I have all this great information to help assist you with what you have encountered. And so just really addressing the patient, definitely the follow-up with the methotrexate. And one thing that I thought about, if I didn't have the emergency from the initial ectopic pregnancy, and if I wasn't a nurse, how compliant would I have been with coming back to this office every 2 to 3 days to get my arm stuck with a needle?
Right.
How compliant would I have been? And so that even makes me think, oh God, patient education is so important. But in order to get that education across to them, we have to first assess that patient.
Right.
Like see where they are mentally to make sure they're even in a good space, dealing with the loss. And then just understanding the dynamics around the pregnancy loss as well. Because if you got a newlywed who's trying to get pregnant and they encounter an ectopic pregnancy, then the feelings may be different than a mom who has multiple children, recently got divorced, or whatever the case may be.
Mm-hmm.
And so we just have to know the dynamics around that patient and how that patient truly feels. And another thing is, and reassure them that it is okay. Like, however they feel, it's okay. You don't want to make that mom who didn't really want the pregnancy. You don't want to make her feel guilty or shameful that she don't feel bad. So It's like you have to be non-judgmental, be unbiased, and just assure them that their feelings are valid. But how do we get to a place of healing? And with the nurses, I know we don't have all the time in the day, but just really just addressing the patient, acknowledging them and how they feel, and then definitely being clear in communicating the patient education, and making sure that they understand, like, what did you hear me say?
Right.
Like, what did you hear me say?
Yeah. You brought a really good point, Shenell, that we just assume every patient is going to be just heartbroken if they find out there's an ectopic pregnancy, but not necessarily. I remember caring for a woman who I was like, all right, so here's the plan. How are you feeling about this? What's your support system at home? Just checking on you, make sure you're okay going home. She's like, can I be honest with you? I was not ready to be pregnant. I don't have the time and the space in my life to take on another pregnancy. This sounds so bad, and I feel so bad saying this, but I'm actually really glad that this is not a viable pregnancy. I can't be pregnant again right now. I got 4 kids. I got all this stuff going on. I was like, you don't have to feel bad in saying that. That is totally understandable.
Right.
You have so much on your plate. I just want to make sure physically now that you're going to be okay, because your body still has some work to do, right?
Yes.
To work through this. So yeah, definitely being aware of what your patient, where they are in their life, that's going to kind of affect the way you give discharge instruction. Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that, because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode.
Yes.
I wanted to add one more thing to it. Sometimes, even me, whenever you're overcome with emotion and someone's trying to give you discharge instructions or important information or follow-up stuff, you can listen and shake your head, but then you go home and you're like, what did the doctor say? What was that? What am I supposed to do next? Did they say this? It's it all goes out the window, even though you heard it, because the emotions were so heavy in that moment. Sometimes you forget it. So whenever I give discharge instructions to patients who just got bad news or, overwhelming news in some way, I will either make personal notes on the discharge instructions, the most important things I want them to notice or highlight them. Or I've even had patients from hey, I'm about to give a lot of information to you. Would you like to hit record on your phone while I'm talking? So if you need to go back later and listen to it, you can. Because I have really clear instructions about how this medication is to be administered, how to follow up, what to expect for signs and symptoms. I did print it here for you, but would you like to hit record while I talk through it? Most of them oh yes, that's a great idea. Let me get my phone out. And they'll hit record, and then I can kind of talk through it very clearly. And then if they get home and they're like, wait, what did she say? They can just hit play, listen to it again.
That is awesome.
So yeah, just remember, you just very good point.
Yeah.
It's not just the science of nursing and explain to the patient the science behind what just happened to their body. The heart of nursing is recognizing where your patient is, what they need from you as their nurse, and it might be different depending on the patient and where they are in their life and what they're experiencing. So thank you for bringing that up, Shenell.
I say see them as an individual. Make sure you see them as an individual and not a medical case.
Right.
Because, we have great nurses out there, but sometimes they miss that little connection piece.
Do you have any examples of maybe someone, whenever you were on the receiving end of care, who maybe didn't word things the best way or didn't respond to the best way? You'd already talked about your doctor and how she kind of empowered you to make the decision in the way she presented the options. But anyone that you're okay, maybe I will make sure not to do that in the future.
I think As far as like receiving care, I feel like they were pretty, like from the time I walked into the clinic to the secretaries, we were pregnant around the same time at one point. And so they were very sincere and genuine. And like they knew what had happened. And so they knew why I was there. So it's just like, how are you? Like their greeting was a little different. Now, when I got to the back, the medical assistant or nurse, they may not have just knew, like they just may have been just working. And so it's like, okay, come on in. I need you to take off your clothes from the waist down and do this. And I'm like, dang, just how am I today? You know, I already don't want to be here. And so it's like, just be mindful to acknowledge the patient. Don't just say, okay, get undressed and the doctor will be right with you. Just ask, how are you?
Let's look past the task of nursing, right? And see the human that's in front of you that's experiencing something really scary and overwhelming. And yes, thank you. Is there anything else that you would have nurses know about caring for patients with ectopic pregnancies? As far as like, I don't know, things to look out for, signs and symptoms, anything at all that you want people to take away from this episode?
So let's just go back to signs and symptoms, because I think that's important. Signs and symptoms of ectopic pregnancy, it varies. Like there's no one pattern for bleeding. There's no one pattern for pain. In my case, it was rectal pain. Someone may experience shoulder pain. So it's just recognizing, just listening to the patient's concerns and educating patients that if you feel like something is off, seek medical attention and don't feel like, oh, well, it's not that bad. I think I'm okay. Or I'm spotting a little bit. Like, go ahead and let your provider know what's going on. I've already talked about like just treating the patient like an individual. I remember the house supervisor just truly being present and making sure everything flowed appropriately. Like I felt like she advocated for me to say, hey, she's pregnant. These are the signs and symptoms that I'm seeing. This could potentially be an ectopic pregnancy that has ruptured. Let's go ahead and get her here. Let's go ahead and do this. Let's go ahead and do this. So there's no delay in care.
Right.
And I thought that was awesome. Like even just getting my husband to the hospital, like we're going to get your husband. We're calling your husband. He's on his way. Like all those things, like just staying in communication with me because I'm scared. I'm in pain. I'm scared. What's going on?
That's good.
What's going on? Did I answer your question?
You did. I thought of one more. The question I always got from patients who I'm discharging with ectopic pregnancy, they want to know, okay, when can I start getting pregnant again? Like how soon can I, we really want this baby, want a baby. Like how can we start again? What did your providers tell you? What advice were you given as far as that goes?
So with the first ectopic pregnancy that ruptured, my provider actually got to take a look at my right fallopian tube during the procedure. And so she was like, I don't really have faith in it. And she's like, I'm going to send you to a fertility doctor. And so which is part of the process of the plan of care, like go see an infertility specialist and see what his thoughts are. And he basically said, I have everything I needed. Go get pregnant. But if I wanted to bypass my fallopian tube, then I could consider in vitro. Fast forward after the second ectopic pregnancy, which I was on birth control to prevent, getting pregnant again. With the methotrexate, I think it's recommended to not conceive within like 6 months.
Okay.
Well, at least 6 months. Another thing, I had the first ectopic pregnancy February of 2016. The second ectopic was exactly a year and 1 month later.
Oh, wow.
I thought that was crazy. When I look back at my, my chart, not in my records within the hospital, but the first emergency was on February the 25th. The second one was March the 25th. I'm like, how? Just looking at the timeline.
So that was 2016, 2017, but then in 2020, you got your rainbow baby.
At the end of 2018, that's when I actually, a year later, we tried, because the fertility doctor said, hey, just get pregnant, try to get pregnant. And we tried, and it was actually in the right location. It was actually in the uterus. But then when we went for, and of course, by this time, I qualified for early ultrasounds.
Yeah.
And so they confirmed it was in the right location early on. And then once it was time to look for a heartbeat, after that 6 to 8 week period, there was no heartbeat. And I was getting ready to go to work after that appointment. And I just told my husband that, hey, I still want to go to work, because my physician My physician, my OBGYN, she basically gave me what my options were. And she was just saying like, hey, you could do the D&C where they go in, dilate the cervix, and they scrape the tissue off the wall of the uterus.
Mm-hmm.
Or I could go home with a medication. I can't remember what the name of the medication was. And it will cause my body to dispel the miscarriage.
Mm-hmm. Yeah.
And so I actually wanted to go to work because I got other medical professionals at work. And I wanted to talk to one of my pharmacist friends and ask her about the medication.
Mm-hmm.
And in that, it ended up sparking a conversation of their own history. And so just hearing one medical profession talk about their experience with the medication versus another one talking about a D&C, I made the informed decision to go with the D&C.
Okay.
Because the situation will be resolved quickly. So yes, put me to sleep, resolve the issue. I'm going to pay more, of course, but it was worth not going through what I felt would have been a more traumatic experience for me at home.
Yeah.
And the risk of still needing the D&C if the medication wasn't as effective as it needed to be. And so that happened. And then in January of 2019, it's something about the first of the year for me, huh? And so fast forward, we just we're not trying to get pregnant. And one thing I can say with being someone who has faced all these issues with having a baby, trying and not trying, is that I told myself that I wasn't going to stress myself out trying to have a baby. And I try to encourage individuals to trust the process, but don't get so wrapped up in the process that it robs you of everything else that you have to live for, that you have to enjoy, your spouse, your children that you may already have, like your family, or if you don't have children yet, your nieces and nephews, like it's okay. So for me, I had told myself, enjoy the baby making process. Don't make it so stressful on yourself that now you can't even enjoy the relationship that you do have with your significant other.
Yeah.
Just being honest. And then move forward. We get pregnant in 2019. We go for ultrasound and it end up, everything's okay. And so fast forward, come 2020, we decide that I'm going to stay home from working in CV because now COVID has reared its ugly head.
Yeah.
And so due in April, we have our sweet rainbow baby. I return back to work and I'm back on birth control because, okay, I got my rainbow baby. I'm good. Get back on birth control. The next year, a week before Luke turns 1, I take a pregnancy test, which I randomly took them because of just my history, just to make sure.
Yeah.
And so I took a pregnancy test and Sarah, it came back positive on birth control.
Girl.
I started laughing. I said, God, you have to be kidding me. We do the ultrasound and girl, this baby is already implanted in the right place with a heartbeat. So I'm pregnant. Didn't even know I was pregnant on birth control.
Oh my goodness.
And so 2021, I have my baby girl.
So you got 2 rainbow babies.
2 rainbow babies. And I didn't even ask for that one. And she is so funny. So I'm like, God has a sense of humor. I'm like, okay, God.
Wow.
And I tell anyone, if you were praying for me, please take my womb off your list. I think we're okay. I think we're okay.
God has answered that prayer.
Yes.
Pray for other things.
Yes.
I love it. Shenell, it's been such a pleasure talking with you about your experience. I feel like you bring so much insight, not just of like what it's like to be the nurse, but what it's like to be the patient and how we can keep that in mind as we approach every patient, wherever they're coming from. I've really enjoyed this conversation. I want people to know where to find you, though, because you have an awesome nursing podcast as well. Can you just tell people, like, what is your podcast? How can they find you? Where can they follow you? All the things.
Yes, ma'am. Well, I have the All One Nurse podcast, and you can find it on any of your favorite podcast platforms, as well as I have the website, allonenurse.com. And you can find me on TikTok, Instagram, and Facebook. And my handle is at All One Nurse. All One Nurse podcast. It's an interview style podcast where I get to interview other awesome nurses like Sarah. And we get to talk about 4 main topics: their professional journey, their personal insights, patient perspective, and of course, educational insights. And so in that, the main thing is the passion that comes behind the reason why that guest speaker does what they do. And that's what I love. They bring that compassionate component to the podcast platform as well. Mm-hmm. It's awesome.
And Shenell, it's so needed in nursing right now. Yeah. I feel like it's a hard profession to be in. And so podcasts like yours are keeping nurses inspired, keeping them going to the bedside with a full cup, reminding them of the why behind what we're doing, not just like all the tasks which we've talked about. There's so many tasks in nursing, but hearing other nurses' stories and what motivates them is so inspiring for us to like take on that same perspective and approach as we care for patients. So thank you for the podcast. And thank you for being on my podcast. It's been such a privilege sharing your story.
Yes, thank you.
All right. Well, is there anything else you want people to know before I let you go?
They can also find you on my podcast.
Yes.
They can also find you on my podcast. So definitely, if they want to go a little deeper about Miss Sarah, definitely come to All One Nurse and learn about Sarah.
Shenell, thank you so much. I'll put all the links in the show notes from your podcast, all your socials. I'll put a link to the podcast episode where you're interviewing me.
Yes.
It's been a pleasure, my friend. Thank you so much for coming on my podcast.
Thank you. So grateful.
Right, have a great day.
You too.
Bye-bye.
Bye.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.